renowned reconstructive plastic surgeon of the country. He was conferred with Padma Shri Award by Government of India in the year 2009 in recognition of outstanding voluntary contribution to the humanity through an excellence in the field of medicine. He was also awarded with prestigious award Sheikh Hamdan bin Rashid Al Maktoum International Award in 2010 by His Excellency Sheikh Hamdan Al Maktoum, the Deputy Ruler of UAE, for volunteer in humanitarian medical services. Can we have that round of applause for Dr. Ashok Gupta?
Thank you very much. Indeed, an honor for me to share my experience. Again, thanks to the first slide. Previous slide before this. Thanks to Dr. Gopinath and the entire team. I'm actually going through 50 years of my journey in the reconstructive microsurgery. My presentation is more of a physical, and I beg your pardon if some of the pictures which I'm sharing could be too ghastly to see, that took pre-lunch time, because some of those defects are reality of life. They are not the figures and data, they are the actual figures. So to start with, I would like to pay my prayers to Sushruta, who was the first plastic surgeon of the world. Even in 600 BC, he had a full knowledge of how to reconstruct the defects, oncology and all trauma, and still he was the first plastic surgeon of the world. As I said, thanking Dr. Gopinath and organizing committee for allowing me to share my journey of 4 decades of reconstructive microsurgery. Reconstructive microsurgery is not a separate specialty, but it's a technique. Microsurgery is a technique which became an integral part of plastic surgery. I was fortunate enough in 1977 when I did my MCH, my examiner asked me, Sunny, what next? I did not know. I thought probably he's failing me and asking me to come back after 6 months. He said, no, you have learned everything what you could learn in India. Now this is the time for you to go for something new. And reconstructive microsurgery was just beginning. 76, the first paper was published, and 77 I was directed to go for microsurgery. And I was there. And during my training in plastic surgery, which Dr. Rath and we are probably all contemporary, born in the same year and graduated in the same year, this was a common practice to see fungating mass on the chest, fungating mass on the, every part of the body. Dr. Gopinath is a witness. He must have also done several like this. I'm a witness. And that time, the approach was conservative, because the surgical colleagues were afraid of dissecting. And only thing available was allow it to heal by secondary intention, leave the fistula, leave the gap, and then do a multi-stage procedure which required fungating mass, inoperable, metastasis, awful looking, awful smell, torture to the family. And the time schedule is used to run in state surgery. We used to transfer in a small skin piece into pedicle format and unnatural position, etc. And this has drastically changed in last 4 decades. And I would say I'm sorry to share this face, which is, we call it a horizontal hemiphasectomy. Half of the face, including tongue, jaw, neck, everything can be dissected. And reconstructive microsurgery, that current generation of surgeons are radical and they are willing to undertake surgery like this, because they know there is a backup of plastic surgery who can take to this stage. The defect, chest defect like this, with a radical mastectomy, now we are willing to undergo surgery. One can be assured. With BRCA1 and BRCA2, ladies are preferring a prophylactic bilateral mastectomy because they know that the reconstruction can be done immediately. And thankfully, this is possible because of the microsurgery. This was the, just to say that there is a changing paradigm in oncological resection. Both reconstructive surgery And reconstructive microsurgery has tremendous impact on the quality of life. This is very important. Post-excision reconstructive work is rapidly evolving. We have 3D modeling technology improving reconstructive microsurgery. We are using local flaps, we are using biocutaneous flaps from a different part of the body, and free flap reconstruction. Free flap is a piece of tissue which is composite tissue, skin, muscle and bone, and we take from different part of the body, bring it to the area where it is required, connect the blood vessels using microvascular technique. 0.2 millimeter to 0.5 millimeter blood vessels are joined. The flow is established, and they work like a live tissue, and they grow like a live tissue. So this is early part. Reconstructive microsurgery enabled us to transfer a live tissue from any part of the body. Post-excision defects of the lesion are best treated with microvascular reconstitution, and restoring form and function, functional integrity of structure of the oral cavity. Cavity include buccal mucosa, dental rehabilitation, and speech, swallowing, and hold food, saliva without leak. These are the aims on oral reconstruction. This is the flap which has been very commonly used, radial forearm flap. Almost it was for all oral reconstruction. This type of resection, I mean, is not very uncommon now. It used to be a common thing in early days. It is not so uncommon now. But we are still, some of the advanced centers are still able to resect this. One of the most common cancer of the head and neck region is the oral cavity cancer. Globally, almost 3 lakh people are diagnosed with oral cancer each year, with 8th most common cause of malignancy. Every effort must be done to reconstruct the defect of primary resection procedure. We have some colleagues from MD Anderson, and they probably do much better work than what we have been able to do. But these are my personal series of almost 40 years and 45 years, which I have been able to do. Like this lady, he had an extensive CA of the floor of the mouth, and she's about 70 plus, but we could still do a primary reconstruction, bringing the flap, constructing the oral floor, constructing the part of the tongue and the lip in one stage. And she went home comfortably. I'm very fortunate that I had, following my MCH and direct, I had chance to have a fellowship at the Royal Master. And that was the center where there were 2 centers. One was in US where Buckhamjian flap started, and then Professor J.S.P. Wilson started the myocutaneous flap and pec major flap. And that made the tremendous change in the head and neck surgery. And that time I would remember, he used to tell me one slogan he gave me, Ashok, surgeons are not remembered by the number of surgeries they have done, but remembered by the number of good surgeons they have trained. And I think that was the key essence which I am carrying forward. And I'm very fortunate to say that since my return, I have trained over 250 residents and plastic surgeons who are expert in microsurgery, and they are able to carry out all the work across the country. Kiyonori Hari, Professor Kiyonori Hari from National Cancer Center, Tokyo, was credited for doing the first free flap in 1976, and he carried forward the work. I'm very thankful to 2 institutions, Grand Medical College, Bombay, and the Bombay Hospital Institute of Medical Sciences, which gave me a platform to carry out all this work, extensive work, with all the support. I would like to share some of my journey of last 40 years, and what we see in microsurgery, success is only a tip of the iceberg. And to be able to see through the invisible is the key to success in these large defects. Under the surface lies the persistence, failure, sacrifice, good habit, hard work, and dedication. I would say good habits because when I was undergoing training in microsurgery, there were 3 crosses out the outside the lab. One was for the skirt, second was for the wine, and third was for the smoking. The reason was smoking, you should not have a tremors, you should have a peaceful night, so there was a cross for the skirt and wine. So I'm very happy, even at 73, still I have a steady hand. So I don't have a tremors now. So that was how we progressed further. This was my first free flap, which I did in 81. This was also the first free flap in the country of India. When in JJ Hospital, we had a central mandibular tumor defect. It was resected. It was the first time in 1981 in JJ Hospital. A latissimus dorsi microvascular free flap, and that was the result. And that became such a big sensation everywhere in the country, including Tata and Delhi and everywhere. They say, no, we never thought that this is possible. I was also, then I started getting all sort of difficult cases, and this was one of the challenging case which Dr. P.A. Shah, JNU Hospital had. And he had a problem. This patient had multiple reconstructive surgery which failed. Forehead flap, shoulder flap, the pec major flap, and almost 2/3 of the face was missing. And there was no donor area available. So this was the first time we could do a Lesmer dorsa from the opposite side, bring it to the area, and then we reconstructed. Similarly, the squamous cell carcinoma of the scalp, which led to complete resection of the scalp, including part of the bone, part of the dura. And then we could do, nobody could think in those days to reconstruct the defect, to close the defect with one single flap. And that is what we did, the Lesmer dorsa muscle with a skin graft. And this was when I used to do, and in a Padma hospital, which is Dr. Rath was doing, there's a small tribal hospital in central India, where I used to go for doing a reconstructive surgery camp. And this was a lady about 60 plus who had a fungating mass. And she was determined to get the surgery done. She was not fit for full anesthesia, so we had to do resection under local anesthesia. And that time, without the microvascular technique, I did a reconstruction using a rib graft, all done under local anesthesia, because patient said, if I'm coming to a center like Padma Hospital, I'm coming to a doctor which has got a full backup, no other center will be able to do it. So we took the risk and undertook this surgery. So there have been several instances where we could do a primary reconstructive flap reconstruction in remote surgical sessions in tribal area like Padar, which I was sharing with Dr. Rath. That was the hospital which had the first radiation center. Even before it came to other center, came through the Nargis Foundation, and we did almost for 5 years, we did over 100 reconstructive surgery. This has been over a period of time, and because we could achieve a good success, like this young boy had a major malignancy removed, we did a radial forearm flap, and afterwards we could do reconstruction of the eyebrow, reconstruction of the hairline. So primary or secondary myocutaneous osteomuscular flap have profoundly changed the contemporary art of reconstructive surgery. And like this patient, I had treated him almost 35 years before. He had a big nerve tumor on the forehead. We resected part of the supraorbital nerve, reconstructed the defect with a radial forearm flap. Then afterwards, I defattened the fat, reconstructed the eyebrow from the scalp. And after that, he came back after 25 years, and I did another radial forearm flap from the other side. So this is all possible because we have the technique of microsurgery. Now this was again one of the gentlemen who had a very large defect of the cheek. And the question was, what type of skin to bring, what type of flap to bring, and he had a defect of the oral cavity also. So with the technique of microsurgery, with excellent surgical options, we could actually fold the radial forearm inside. Part of the radial was used for the oral mucosa, was used for the composition of the lip commissure, and then the surface also. So this is all achieved only because of I'm sure the older technique medical would have taken more than 6 months to 1 year to achieve this with a lot of cicatrization and lots of difficulties. Is one of the major challenges and one of the major achievements which we have been able to do it. Mandibular defect part of the mandible has been removed, and it is only because from 1983 Hidalgo had published this paper from Sloan Kettering where we can use the part of the mandible and shape the mandible. This is the only bone in the body which can be divided into multiple small segments, shaped like a mandible, and it can continue to act like a live bone. So this is one of the examples of mandibular reconstruction. Mandible can be divided to half. It will still remain live. So vascularized bone with intact endosteal and periosteal blood supply. With microvascular anastomosis of vascular pedicle to a major recipient vessel, the transplanted segment behaves like a denominated segmental fracture, heals both ends. The medullary cavity gets unified and continues, and grafted bone acquires the size and strength of the matching with the recipient side. So this double barrel mandible fibula and triple barrel fibula are being using now for very large defect post-sarcoma excision, femur, tibia. So the reach has extended. For sarcoma at one time, amputation was the only available treatment. Now we are able to save the limb and we are able to reconstruct the defect. So this can be done for both sides. Like this gentleman had a very large tumor extending on the both sides. So we resected the entire mandible, shaped the fibula into mandible, divided into three parts, the central part, the right and left side, divided this, shaped in the situ, and this is the picture after the mandibular reconstruction of total mandibular reconstruction. Like this lady also had a resection, oral mucosa, oral and mandibular resection, and the result shows 3D modeling. 3D CT scan shows the complete reconstruction of mandible, and this also shows the complete rehabilitation without any oral leak, without any difficulty, and she is able to almost like 7 years post-operative follow-up. Major challenge which has been overcome by microsurgery is a esophageal reconstruction. Laryngopharyngectomy was a major issue which lot of the fistula, etc. So I was also credited with the first jejunal transfer for esophageal reconstruction. This was again done in 1982. We could take a segment of jejunum, isolate the tube based on a vascular pedicle here, then transfer to the esophagus, cervical esophagus, anastomose to the carotid vessel there, and we could see the complete esophagus. This is what the esophagus has been working here. And this is the post swallowing this. You can see the anastomosis and you can see the complete rehabilitation of patient with jejunal reconstruction. And this 83 was surgery done. We have done a follow-up, and there's a complete change of the mucosal lining from jejunum to esophageal change. So this is something which could be achieved only through the scope of reconstructive microsurgery and primary reconstruction. Thanks to our radiation oncology in early days, this was somewhere in late 80s. This lady with a CA breast was heavily radiated, and not only the breast tissue, but entire chest, entire ribs, and even the pleural thing was totally burned out. And it was a big challenge how to reconstruct it. First thing was to resect that area, restore the lung function, restore the pleural lining, and at the same time reconstruct the defect. So this is how I took part of the omentum, separated from inside, removed the omentum, anastomose, and brought it to the chest wall. So this is how the omentum was used. In those days, nobody could think that we can bring the intra-abdominal structures for an extra thoracic reconstruction. So this is how the omentum was isolated on a vascular pedicle. It was brought an anastomose here, and then this is how the lady has recovered completely and healed. Major changes in reconstructive surgery in last 22 decades have been for breast reconstruction. Tissue flap procedures using own tissue either from abdomen or back to create a bond. Taking abdominal skin called as stem flap, and tissue flap taken from the backside is called as Lesmer's also. These are very commonly used flaps which I've been using for the last 30 years, and I wish we pointed. So this is how we take the skin based on the rectus abdominis. Other side we take a skin and muscle based on the Lesmer's dorsal, and we can bring and do a primary reconstruction of the breast. Any type of it can be done on both sides, it can be done on one side. And like I said, even nowadays people are going for prophylactic mastectomy. In those cases also we are able to reconstruct both sides breast with one flap. So psychological implications of a deformed breast post-excision is very high. Prospects of losing the sign of femininity, the breast and ending up with a scarred, deformed and flat chest is not palatable or proportion. Reconstruction of breast has been made easier by modern microsurgical techniques, and more patients are accepting an early breast reconstruction as part of the whole surgical treatment of the cancer of the breast. And I'm sure Dr. Gopinath is a witness to number of patients accepting the breast reconstruction and breast surgery following this reconstruction. So this is one of the very commonly used method. We take the spherical muscle on the back, there's a latissimus dorsal muscle. We take a skin paddle and then it is brought inside. Afterwards, at second stage, we do reconstruction of the nipple and we also do reconstruction of the nipple areolar complex. Same thing here like the breast. The shape of the reconstructed breast will gradually improve over months. Minor adjustment in size, position of the breast can be carried out when the nipple areola are rebuilt, and breast reconstruction doesn't alter the chance of cancer coming back nor interfere with the future treatment. That's what, but with this technique, the breast surgery has become much more acceptable all over the country. A lot of oncologists are willing to undertake surgery. This is some of the patients of secondary reconstruction which I have done by using the latissimus dorsal muscle and doing a nipple areolar reconstruction using the rectus abdominal muscle transfer and breast reconstruction. So these things in last 20 years time, the maximum number of breast surgery across the world is because of these two flaps. Now we'll come to the third part of the microsurgical innovation, that is the bone tumors. Advances in microsurgery and ability to reconstruct large tissue and bone defect using a live bone graft has been the major, it has opened a new chapter in bone tumor reconstruction. With Dr. Patel here, specialist in sarcoma, so we appreciate how we can transfer a vascularized fibula for a radical excision of the osteoclastoma, osteosarcoma. Possibility of shaping the bone graft by serial osteotomy without compromising strength and adaptability to different needs have made these composite tissue transfer a choicest procedure over any other plastic material. This was a young lady who had a osteosarcoma of the lower end of the tibia. It was resected completely and she was left with a huge defect. And then I used that vascularized fibula graft primarily for reconstruction, and this is the last X-ray shows the complete rehabilitation of her. Another patient who had a post-surgical defect who had a osteoclastoma of the upper end of the tibia which was resected. She had a recurrence, she had the joint replacement, she had a recurrence which was resected, and then I have gone for a triple barrel fibula or double barrel fibula because the strength of single barrel fibula for the lower extremity is not so good, so we are going for a double barrel fibula for reconstruction of this. So fibula is a long bone, twice the length of the defect is harvested, half perpendicular to length, resulting in stud folded upon each other, which is called as a double barrel fibula. And similarly, I can have a fibula from the other side to make it triple barrel fibula. So this is again a physical characteristic of the bone. So this was the case of an osteogenic sarcoma of a young boy, of a femur. And that time, one of the well-known orthopedic surgeon in Bombay Hospital, he said the only option is amputation. But with my association with them, he said, why not do a reconstruction? So this was the first time I did a vascular bone transfer for osteogenic sarcoma, and this is the result. The double barrel fibula was fixed to the femur, longer segment was telescoped into the medullary canal, and shorter segment was interposed as a graft with the screw fixation. Full weight bearing only after graft laparoscopy, which is 18 months. And this was the result of the patient, young boy, having full function of the knee and full function of the limb, and live for many years. So full range of movement, salvage of the limb, minimum recovery time, stable solid bone reconstruction. The bone scan and MRI did confirm the survival of the bone graft. This is the triple barrel fibula, which is in a case of a osteoclastoma of the upper end of the tibia. So this is how I'm just posing. So this is how the consolidation of bone graft you can see. This is how the stable rigid osteosynthesis, bone reconstruction with double barrel fibula shorten the consolidation time. Vascularized double barrel fibula graft yield yielding strength for early weight bearing without the need for any bone hypertrophy. And this is the again osteoclastoma of the upper extremity, resected and completed with the fibula graft. So in my experience of almost like 30 years, we had about 118 patients with osteogenic sarcoma or osteoclastoma, upper extremity and mandible and this thing. And so I would say my journey of last 45 years of reconstructive microsurgery has been difficult, demanding, dedicating, exciting, but at the same time rewarding. And plastic surgery is an art form, an exciting discipline whose effectiveness often depends on the harmonious blend of medical science and art. To transfer a bulk tissue and maintain its viability is an applied science, but to shape the tissue into graceful anatomic form is an artistry, and microsurgery has allowed us to share both the science and the artistry also. And I'm very happy to share that considering the contributions and development of microsurgery, I was honored by the Honorable President of India and Honorable Ruler of Dubai for conferring the award. Thank you very much to Dr. Gupta. Thank you.